Hi, this is Rachel Hine and Heather Levitas, Duke Plastic Surgery residents on Resident Review, a plastic surgery lecture series. This is a lecture series designed to aid in preparation for our yearly in-service examination. Our goal is to take you through high-yield topics along with experts in the respective fields in order to maximize your knowledge and potential scores. Much of this lecture is going to be focused on embryology of the head and neck region, although anatomical considerations related to cleft lip, palate, and the cranial vault will be left until those respective lectures. This lecture is more of a potpourri, if you will, of anatomy topics.
Not the most interesting cast, but we'll do our best to spruce it up as we're discussing a smatter of high-yield topics on the in-service. Let's get started. First, a discussion of branchial, also known as pharyngeal, synonymous, arch structures. So let's start first with neural crest cells. They're a set of ectodermal multipotent cells that migrate into the region of the head and neck and induce the differentiation of the tissue they invade. Pharyngeal arches, these originate from these neural crest cells, surround pharyngeal endoderm and mesoderm. Each arch is separated by pharyngeal grooves externally and pharyngeal pouches internally.
Now I'll try to give you a discussion of how to remember each of the commonly tested branchial arch structures, starting with the first arch. Think first arch, massive list of M's. So going down from M's, we'll start with our nerve, maxillary and mandibular nerves. We have our maxillary artery. We have Meckel's cartilage. This gives rise to the mandible plus the sphenomandibular ligament, the malleus, and the incus. For our muscles, we think MAT times 2. So that's going to be our acronym. The muscles of mastication, the mylohyoid, anterior belly of digastric, the anterior 2/3 of the tongue, the tensor veli palatini, and the tensor tympani.
All right, so first pharyngeal arches or branchial arches are the M's. The second arch, you want to think second S or S's. So for the nerve, you have the seventh with an S, cranial nerve or the facial nerve. The artery is the stapedial artery and the hyoid artery. Unfortunately, that's not an S. But then for the cartilage, you have stapes, styloid, stylohyoid ligament, and the lesser horn of the hyoid. And then finally, muscles that are associated with the second branchial arch are the muscles of facial expression. So for the S component, you can think smiling, the stapedius muscle, the stylohyoid muscle, and the posterior belly of digastric. That doesn't really work, but posterior with multiple S's, and then it fits.
So for the first arch, we have our cranial nerve 5, and then our second arch, we have cranial nerve 7. And then moving on to the third arch, the third branchial arch, we think glossopharyngeal nerve, which is nerve number 9. The glossopharyngeal nerve is the taste sensation for the posterior 1/3 of the tongue. We have the greater horn of the hyoid, so not the lesser, it's the greater G. And then we have our stylopharyngeus muscle as well.
All right, and then moving on for the fourth arch, the things you want to think in your head to remember the fourth arch structures are swallowing, and then anything that's not the sixth arch, which we'll talk about next. So it's sort of a catch-all. So the nerve is the superior laryngeal nerve, which is a branch of the vagus nerve. The cartilage becomes the thyroid cartilage. And then for muscles, you have the pharyngeal constrictors, levator veli palatini, and the cricothyroid. So you've got swallowing and then the thyroid cartilage and the cricothyroid muscle. So then for the sixth arch, you want to think speaking or laryngeal. So for the nerve, you have the recurrent laryngeal nerve, which is also a branch of the vagus nerve. The cartilage becomes all of the laryngeal cartilages except for the thyroid cartilage, which was the fourth arch. And then the muscles of the sixth arch are all intrinsic laryngeal muscles except cricothyroid, which is the fourth arch, which we talked about before.
Next, we'll talk about the pharyngeal grooves. We just talked about the pharyngeal or branchial arches. Groove number 1 becomes the external auditory canal. Grooves 2 through 4 create the cervical sinus, and so failure to obliterate results in pharyngeal cleft cysts, which are sealed within the neck, sinuses, or an end in a blind sac, and fistulas, which connect with the pharynx. These anomalies are often detected in the second decade of life, and they're palpable at the anterior border of the sternocleidomastoid. Anomalies from groove 2 are most common, run between the internal and external carotid arteries towards the tonsillar fossa. For our pharyngeal pouches, we have 5 of them. The first one is internal auditory canal, and that correlates with the groove 1, which becomes the external auditory canal. Pouch 2 is our palatine tonsil, and pouch 3 is our inferior parathyroid and thymus. Pouch 4 becomes our superior parathyroid as it migrates above pouch 3, and then pouch 5 is our thyroid C cells.
The unbelievable part of all of this to me is I thought in med school I would literally never have to learn any of this ever again after step 1.
But here we are.
Here we are,
Every year.
Plastic surgery residents, almost approaching chief year, and we still have to memorize this stuff every single year for the exam.
I have to be honest, I have no good way of memorizing this.
Yeah, that whole S thing and the M thing was not the best, but it's all we've got, everyone, so we apologize. Just know that you're not alone. All right, so next we're going to talk about formation of the face. The face develops from 5 different prominences, 1 frontonasal prominence in the midline, 2 maxillary prominences, and 2 mandibular prominences. The frontonasal prominence is pulled ventrally and caudally, and it forms the forehead, the nasal dorsum, and the medial and lateral nasal prominences. Also part of the frontal nasal prominence are the nasal placodes, and these develop into the nasal pits, which eventually form the nares. Additionally, we have the medial nasal prominence, which forms the primary palate, the mid-maxilla, the mid-lip, the philtrum, the central nose, and the septum. And then finally, the lateral nasal prominence forms the nasal ala, So then moving on, the 2 maxillary prominences, these migrate medially to form the secondary palate, the lateral maxilla, and the lateral lip. Junction with the lateral nasal prominences forms the nasolacrimal groove and the nasolacrimal duct system. Failure of fusion with the lateral nasal prominences results in an oblique facial cleft, Tessier cleft number 3. The mandibular prominences form the mandible, obviously, and the lower lip and lower face. And then finally, the thyroid. This is from endodermal proliferation of the foramen cecum of the tongue. The thyroid descends with a trailing thyroid diverticulum to its final position distal to the cricoid cartilage. This is relevant because thyroglossal duct cysts can form anywhere along this path, and these, as we're tested on, are the painless midline neck masses.
And Heather, this is kind of off the cuff, but I think they had a question this year on resection of a thyroglossal duct cyst.
Yep.
And the things that you have to remove as a part of that.
Oh, gosh, I remember that question.
And the answer was you remove the cyst as well as a portion of the hyoid bone.
That's right. Wow.
So that's a good little tidbit when you're taking these out, is those require not only removal of the sinus itself, but also a portion of the hyoid bone.
Yeah. All right, so dry but high yield stuff, like we said. And then finally, lingual thyroids form from failure of descent of the thyroid. Really, that's what that is. All right, so that's some of the head and neck anatomy that we're going to start with. And the next up, we've got a question. So this is a question from the 2017 exam. A 6-year-old boy is brought to the office because of a draining sinus in the midline of the neck. His mother reports that the drainage developed after he had an upper respiratory infection a few weeks ago. Physical examination shows a palpable mass in the mid-third of the neck that moves upward when the patient protrudes his tongue. Which of the following is the most likely diagnosis?
So there's a few things in this question stem that you want to look at before you answer. The first one is he's got a draining sinus in the midline of his neck. So we know that thyroglossal duct cysts form in the midline of the neck. It's also painless and moves upward when he protrudes his tongue, which is also very key when you're diagnosing thyroglossal duct cysts. If they have a failure of the foramen cecum to obliterate, then that will be connected to that cyst and it will move upwards as the patient swallows or protrudes his tongue. So we gave the answer away, but the answer is thyroglossal duct cyst. And just to kind of review a little bit of the anatomy for the anterior 2/3 of the tongue, it's from the first pharyngeal arch and it's innervated by the lingual nerve, which is part of cranial nerve 3. And then cranial nerve 5, the third portion. And then for the posterior third of the tongue, you have the 3rd and 4th arches, and that's innervated by the glossopharyngeal nerve, which is taste, and also the vagus nerve. Our next question is from the 2012 in-service examination. We'll go through that quickly. This is a 50-year-old man undergoes a wide local excision and bilateral selective cervical lymphadenectomy because of a 6-month history of invasive squamous cell carcinoma of the interior floor of the mouth. Free tissue transfer using an anterior lateral thigh free flap, including harvest of the lateral femoral cutaneous nerve, reconstructs the ventral glossectomy and floor of mouth defect. Which of the following is the most likely recipient nerve for functional sensory recovery of the free flap in this patient?
The answer to this question is lingual nerve.
And we just went over that. So if you're taking the lateral femoral cutaneous nerve from the ALT flap, which can provide a sensate flap for that, you want to give sensation to the anterior 2/3 of the tongue. So if we remember that's from pharyngeal arch 1, which is cranial nerve 5. The posterior third of the tongue is the 3rd and 4th, and that's cranial nerve 9 and 10. So if we look at all these, we have nerve 7, we have a great auricular nerve, we have nerve 12, the hypoglossal nerve was an option, the inferior alveolar nerve was an option, and then finally we have lingual nerve. So out of all of these options, the lingual nerve is the only one that gives any kind of sensation to the tongue.
All right, and now Rachel's going to give us a little overview of the anatomy of the external ear.
So the external ear, it forms at the junction of the pharyngeal arch 1 and 2. Arch 1 has 3 anterior hillocks, and arch 2 also has 3 posterior hillocks. And the anterior hillocks include the tragus, the root of the helix, and the superior helix. And so kind of the upper medial portion of the ear. And then the arch 2 is the 3 posterior, so the antitragus, antihelix, and the lobule.
You know, it's at some point we have to think about passing the torch along to some of our junior colleagues. We have Dr. Rosie Tillis with us today, and her first foray into the Resident Review podcast is going to be a little overview of some really exciting dental anatomy.
As the junior on service right now, I get to play the role of dentist. So, a little review of dentition. Kids start out with their pediatric primary deciduous baby teeth, 20 teeth. You start with 4 incisors, 2 canines, and 4 molars per arch. There are no premolars in pediatric dentition. Pediatric dentition is referenced by letter beginning with the upper right second molar to the upper left second molar, A through J, and then you jump down to the lower left second molar and swing around to the lower right second molar. A person is reported to have mixed dentition when they are in the period when they have eruption of the first adult tooth, commonly the mandibular first molar, and then some baby teeth as well. Adults have 32 teeth, 4 incisors, 2 canines, 4 premolars, 6 molars, and that one is referenced by the numbers beginning with the upper right third molar. The eruption sequence usually starts with first molars at around 6 to 7 years. Your incisors are at around 6 to 9 years. Canines come in at 9 to 12. First premolars come in at 10 to 11 years. Your second premolars come in at 11 to 2 years. Your second molars come in at 11 to 13 years. And your third molars come in at 17 to 21 years old.
Yep.
So, Rosie, we have a baby, and they just erupted their first adult tooth. What's the most common adult tooth?
Well, it looks like in order of the most common teeth to erupt, the first molar,
Mandibular or maxillary?
the mandibular first molar is usually the first one to come up.
Oh man, 99%.
99%.
Do what
Awesome. That's great. So that's frequently asked. The first adult tooth is going to be on the mandibular side rather than the maxillary side. It's going to be your first molars. The last ones to come in are your third molars or your wisdom teeth. And then there's ones in between that you'll kind of have to know as we go along. Thank you, Rosie.
All right, next. So this is a question from the 2016 exam. Which of the following tooth types is most commonly the last one to erupt when the primary teeth are replaced by permanent teeth?
So for our options, we have maxillary canine, maxillary central incisor, maxillary first molar, maxillary first premolar, or maxillary lateral incisor.
Well, it would have to be the maxillary canine.
You got it.
Because if like we talked about, or like Rosie taught us, the third molars come in last, but they're not listed there. And so the ones that come before that are going to be your second molars, second premolars, and then finally your canines. And that's the one that is, out of all those, the last to erupt. So knowing the sequence is important as well.
All right. We were going to have Rosie continue on with some more anatomic discussion, but I think I'll relieve her from the next couple topics because they're so dry. All right. So stages of tooth development. The first stage is initiation or proliferation. Then you have the bud stage, which is the appearance of the tooth bud without a clear arrangement of cells. Next is the cap stage, which is the first sign of arrangement of these cells. And next is the bell stage, which is known for morphodifferentiation. Failure of this leads to anomaly of the enamel, dentin, and cementin composition. And then finally you have the advanced bell stage. And that's sort of where my knowledge of tooth development ends. In terms of anatomy, there are 3 components. You have the root of the tooth, which is the part in the bone, the neck, and then the crown, which is the part covered by enamel. From external to internal, you have the gingiva, the bone with nerve and blood vessels. Then you have cement, which covers tooth root only. And then you have the dentin, which is the yellow layer, the pulp cavity, and then the root canal. So next we'll proceed with a question.
This is from a 2017 exam. A 5-year-old child is brought to the office for evaluation of several supernumerary teeth. Which of the following is most characteristic regarding this anomaly? A is more common in the primary dentition than secondary dentition. B is more frequent in the maxilla than the mandible. C is more prevalent in females than in males. D, this occurs most often from disruption during the morphodifferentiation stage of tooth development. And E is that this is typically associated with ectodermal dysplasia. So which of these answers is most common in people with supernumerary teeth?
Talking about hyperdontia,
Yeah.
which is the anomaly in the number of teeth. Heather, where does this most commonly occur if you have hyperdontia or supernumerary teeth?
So supernumerary teeth, I believe, are more common in the maxilla of about 90%.
So that will occur during the initiation or proliferation stage. It's more common in males rather than females, and it is 5 times more common in permanent dentition than in primary dentition. And finally, ectodermal dysplasia is associated with hypodontia. So when we look at our answers here, more common in primary dentition than secondary dentition is going to be incorrect. It is more frequent in the maxilla, so that is the right answer. It's more prevalent in males, not females. Hypodontia, not hyperdontia, is associated with ectodermal dysplasia.
Rosie, do you want to talk about dental cysts?
Sure. There are multiple kinds of dental cysts. First of all, is periapical dental cyst, which is the most common. It develops from necrotic pulp after tooth infection and is also associated with mandible fractures. It is also known as a radicular cyst. These are periapical cysts. Next kind is dentigerous cysts. This develops in the follicle from an unruptured tooth, and it is lined with non-keratinizing epithelial cells. This is the second most common type of cyst. Third type is odontogenic or primordial cyst. This develops inside of a tooth and is lined with epithelium. The next kind is gingival cysts. These are superficial cysts in the gingiva, and it contains keratin. The last kind of dental cyst, a residual cyst, and this is a retained periapical cyst after the tooth has been removed.
So how could we tell a difference between, if we're looking at a picture, a periapical, which is very common, versus a dentigerous cyst? Like we know, like you said, the dentigerous cyst will develop in a follicle of an unerupted tooth. So on the x-ray, you'll see a tooth that has not erupted, and it will be a cyst around that. For periapical, it will be at the apices of the tooth itself, which is going to look a little different from an unerupted tooth, and that's kind of how you can tell the difference, but I still always get those confused.
Periapical cysts, I just think of people with bad teeth, get them from tooth infections, and it just gets necrotic and kind of gross.
So that would be like a bubble at the bottom of the tooth, whereas a dentigerous cyst would be like a tooth inside of a bubble.
Yes.
Exactly.
And now, do you want to talk about some benign dental tumors?
Yeah, I do, actually. So an ameloblastoma is a slow-growing tumor. It occurs in your 40s or 50s from odontogenic epithelium. So on x-rays, you'd see a radiolucent multicystic unilocular lesion, and these are treated by a segmental mandibulectomy and reconstruction. There are also keratocystic odontogenic tumors. These are aggressively local.
So aggressive and so local.
So local, they're all
Sounds
about
like
it.
some guys I know.
Yes.
Anyway.
So,
Hold together.
the next type of tumor are keratocystic odontogenic tumors, which are aggressive locally. They occur late in life, and they're also from odontogenic epithelium. The treatment for these are enucleation with chemoablation with Carnoy solution.
I use that all the time.
All the time.
The last type of benign dental tumors are neurofibromas. These are expansile lesions of the inferior alveolar nerve canal.
So we have a
Awesome.
few highlights from this, and I think they're always asked. We talked about when you see a cyst and you're able to identify it, whether it's periapical or dentigerous, or you're looking at something that looks like an amelioblastoma, they'll often ask what kind of epithelium it is. So just remember, for amelioblastoma, it's going to be your odontogenic epithelium.
Mm-hmm.
For your dentigerous, it's going to be the non-keratinizing, like we talked about. For the neurofibromas, this is also frequently tested. These will be the expansile lesions in the area of the inferior alveolar nerve canal, and those are ways that you can tell the difference of those.
Does anyone remember which of the benign dental tumors are associated with Gorlin syndrome?
I do, so confidently. It's the keratocystic odontogenic tumor.
Is it keratocystic or keratocystic?
Whatever you want it to be.
Tomato.
Yeah, tomato.
But 75% of patients with Gorlin syndrome has this finding.
Good. Look, we're tying things in. And what kind of skin cancer do people with Gorlin syndrome get?
I think it's a basal cell
Yep,
carcinoma.
yep.
Exactly.
Basal cells. So moving on from teeth, we're going to talk about the carotid artery anatomy, and we're going to go with the less colorful version of the external carotid artery. An acronym? Acronym? Sorry. Anyway, some attendings like freaking out potential medical students. So that stands for S, superior thyroid, A, ascending pharyngeal, L, lingual, F, facial, O, occipital, P, posterior auricular, M, maxillary, and S, superficial temporal. Some attendings like freaking out potential medical students. That's the one we're going with. Which of the following is the most common origin of the superior thyroid artery?
So let me think about this. Some attendings like freaking out potential medical students. So we have the bifurcation, the common carotid, external carotid, and internal carotid. And I feel like we just talked about that acronym that had the superior thyroid artery coming off the external carotid artery. So that's my answer.
Next, we're going to talk about neck trauma. So we're kind of jumping all over the place. Rachel's going to take us through the zones of injury.
So we have 3 zones of injury for penetrating neck trauma. Sometimes we'll get called in for these. The zone 1 is going to be your inferior most zone, and that is clavicle to cricoid cartilage. You have your great vessels there, your subclavian vessels, brachiocephalic veins, common carotid arteries, aortic arch, and jugular veins. You also have your trachea, esophagus, lung apices, cervical spine, spinal cord, and cervical nerve roots. For your second, it is the cricoid cartilage to the angle of the mandible. And that is going to be your carotid and vertebral arteries, jugular veins, as well as your pharynx, larynx, trachea, esophagus, cervical spine, and spinal cord. Some high
High-stakes real estate?
stakes real estate, exactly.
Yeah.
And then the zone 3 is the superior most, and that's going to be a little posterior as well. That's the angle of the mandible to the base of the skull. And these are your salivary and parotid glands, as well as your esophagus, trachea, vertebral bodies, carotid arteries, jugular veins, and spinal cord. So moving on to relevant in-service question. This is from 2016. A 17-year-old boy is brought to the emergency department because of profuse bleeding from a stab wound to the neck above the angle of the mandible, anterior to the sternocleidomastoid muscle. After airway stabilization is established, vascular repair of a laceration of the jugular vein is performed. Where is the injury located? So if we remember, zone 1 is clavicle to cricoid, zone 2 is cricoid to angle, and zone 3 is angle to base of skull. So this is anterior to the sternocleidomastoid and above the angle of the mandible. So I'm going to go with zone 3, which is going to be angle of mandible to base of skull.
Leave it to Rachel to answer her own question.
Oh, sorry.
That's okay. So next we're going to go through some of the skull foramens. These are the exits of the cranial nerves. Facial nerve comes out the stylomastoid foramen. The internal carotid artery comes out the foramen lacerum. The maxillary division of cranial nerve 5 comes out the foramen rotundum. The mandibular division of cranial nerve 5 comes out the foramen ovale. And then cranial nerves 3, 4, and 6 come out the superior orbital fissure. And compression or injury to these nerves leads to superior orbital fissure syndrome. Related concept to this is the orbital apex syndrome, which is basically superior orbital fissure syndrome plus cranial nerve 2 or optic nerve involvement, and that's sometimes tested. Moving on, the middle meningeal artery and vein come out the foramen spinosum, and the glossopharyngeal, vagus, and spinal accessory nerves come out the jugular foramen. Moving on to sinus drainage into the nose. I know we're kind of jumping all over the place here, but we all gotta get all this head and neck anatomy covered somehow. The superior meatus drains the sphenoid sinus and the posterior ethmoid air cells. The middle meatus drains the maxillary sinus, and the inferior meatus drains the nasolacrimal duct, which is important for placement of Crawford tubes, especially in facial trauma. We have some more kind of random relevant nerve anatomy that we get tested on in addition to its implications for anomalous innervation. Arnold's nerve, which is the vagus nerve, branch of the vagus nerve, provides sensation to the palate and external auditory meatus. This is relevant when you're performing an ear block. The glossopharyngeal nerve provides parasympathetic innervation to the parotid gland. And then related is Frey syndrome, which is gustatory sweating, happens after a parotidectomy. And it's really what it is anomalous reinnervation of the auricular temporal nerve, which normally supplies sensation to the upper helical rim. It can also occur after repair of a condyle fracture.
And that's anomalous reinnervation of parasympathetic fibers to your auriculotemporal nerve, which makes you salivate.
Yep. So moving on to some questions. This is from the 2015 exam. A 24-year-old man with a history of left facial trauma and condylar fracture of the mandible is evaluated because of redness and perspiration of the left cheek and ear after ingesting certain foods. Aberrant regeneration of which of the following nerves is the most likely cause of this patient's symptoms? Is it A, auriculotemporal, facial, greater auricular, inferior alveolar, or lingual?
Well, I remember our conversation very recently about Frey syndrome. And I'm thinking this is going to be auriculotemporal nerve.
So this syndrome is thought to result from damage to auriculotemporal parasympathetic nerve fibers with subsequent aberrant regeneration and innervation of sympathetic fibers to the sweat glands. Finally, we're going to finish up with some more random parotid anatomy. Rachel?
So this is parotid anatomy that's not tumors. So when we think about things that can get injured, we have our Stinson's duct that can occur after trauma, and what you form is a sialocele from that. Where is this located? So this is located adjacent to the maxillary second permanent molar. That's frequently tested. This can cause a salivary fistula. Treatment is antibiotics and anti-sialagogues. Is that how you say that?
Mm-hmm. I think so. So anyway, this sort of mini podcast is going to serve as the preamble to the podcast episode that I recorded with Dr. Rachel Analik before her graduation with Dr. Yu. So stay tuned, and that's coming up next. Good afternoon, good morning, good evening. Thank you everyone for tuning in to our podcast. We have today Dr. Ron Yu, who's professor of plastic surgery at MD Anderson and has been there since 2001. He specializes in head and neck reconstruction, has over 100 peer-reviewed publications. He's listed as one of America's top doctors on U.S. News and World Report, and he today served as the Barwick Visiting Professor at Duke. So we're very happy to have had you here today. Thank you so much for visiting us. I'm Heather, one of the PGY4 residents. We also have one of our chief residents with us today, Dr. Rachel Analik, who recently found out that she was accepted to Memorial Sloan Kettering's Microsurgery Fellowship next year, so we're very proud of her. Mm-hmm. We also have Dr. Phillips with us today, who just finished up his Microsurgery Fellowship at MD Anderson and considers Dr. Yu one of his mentors. So thank you, everyone, for being here with us today. So would you mind just telling us a little bit about yourself, what sorts of surgeries you specialize in, and anything else you want to share with us?
I initially I didn't know anything about plastic surgery. I trained in China, in Beijing, in general surgery. Then I came to the United States. I restarted general surgery residency. I found out that I needed something more technically challenging. So that's how I got into plastic surgery. And then I fell in love with microsurgery right away. And then one of the kind of most challenging areas of reconstruction is head neck reconstruction. So I just love it, and I started doing head neck reconstruction during my residency, and all these flaps. I love the flaps and the complicated reconstruction. So when I got to MD Anderson, I just focused on head neck reconstruction. So this is where my passion is.
So we heard a little bit about this morning at our lecture, but could you talk a little bit about your approach to esophageal reconstruction and what sorts of things you've learned throughout your career and sort of where you've taken your reconstructive approaches?
Yeah, when I first started at MD Anderson, the most common flap we used for esophageal reconstruction is the jejunal flap. And then we realized that it's a big surgery for a lot of these head neck cancer patients. A lot of them are smokers, drinkers. They're not very healthy. So another abdominal surgery is really kind of risky for them. So then during my residency, I did a lot of LT flaps. I thought that's a good flap to use. And so we started using the LT flap, and so you don't have to open the abdomen, so a lot easier for the patient, and you don't have to coordinate with another, let's say, general surgery to hook up the bowel and close the abdomen for us. So it makes a lot easier for patients and for surgeons as well, and they recover faster. So that's then we started using the LT flap and the radial thigh flap. And then we also realized that for these patients with a total laryngectomy, they don't have a voice box, and how are they going to talk? Right? So we have to puncture a hole between the esophagus and the trachea to make a fistula for them to talk. And with the small bowel for the reconstruction, the small bowel is too soft and it doesn't vibrate well, so the speech is terrible. And with the skin flap, skin vibrates like a drum, so their voice is much better. So that's kind of another advantage of the skin flap. So that's our approach now for these pharyngoesophageal reconstruction, and it's been working great.
So we heard a little bit about this, but can you talk to us about the advantages and the disadvantages of using a free jejunum versus an ALT?
Yeah, so I can touch a little bit already. Yeah, the jejunum and ALT, the jejunal flap requires a laparotomy and abdominal surgery, bowel surgery, so there tends to be a lot more surgery. Many patients with high-risk patients, they cannot tolerate such a big surgery, and so their recovery is longer, and they, with the jejunal flap, the voice reproduction is not good because the jejunum doesn't vibrate well. With the ALT flap, it's a skin flap, so it vibrates better, so the voice is better, and also you don't have to open the abdomen, you just take a piece of skin from the thigh. It's kind of, surgically, it's no big deal, it's a small surgery. But the bowel has its own advantage because the bowel is, you put it in the neck inside for esophageal reconstruction. That's like its native environment, so it heals very well. It heals within a week. Versus you put a skin, basically you soak the skin in saliva 24 hours a day. It's like the skin will macerate, so that's why the skin flap heals more slowly. So that's probably how sometimes you get a delayed fistula. So that's kind of a disadvantage of the skin flap. But just because it's easier for the patient and less surgery and the speech is better, so it becomes a more popular flap.
Mm-hmm. So you've mentioned that speech is better with an ALT flap, but which flap do you think is better in terms of swallowing for the patients?
Yeah, swallowing, I would say it's probably about the same. People think that with the jejunum, it has peristalsis. It may help with the swallowing if you you do the hook up the bowel in the right direction. But actually, we see a lot these during barium swallow study because you put the bowel in the neck, it's not coordinated peristalsis anymore. So it's not like when you want the food to go down and the peristalsis helps it to go down. It's not coordinated like this. So a lot of times we see that when the patient try to swallow and the bowel starts to move, contract, then you can see the spasm and just standing there for many minutes. Like one case we saw for 5 minutes. The patient trying to swallow and it's like a choke for 5 minutes. He can't swallow at all. Then all of a sudden it releases. Then it goes down. So it's not coordinated peristalsis. But I think overall swallowing function is probably about the same.
When do you allow patients to eat after esophageal reconstruction, and when do you get that barium swallow that you mentioned, and how often are patients able to successfully eat after your reconstructions?
Yeah, in patients without prior radiation therapy to the neck, and these patients can heal faster, so we wait for about 2 weeks after surgery. Then we give the patient a barium swallow study first, make sure there's no leak inside, and also make sure that the patient can swallow without problems. Now, if the patient had radiation already in the esophagus before surgery, and then they heal really badly, and we wait for 6 weeks, and then give a barium swallow study, and then if they pass the swallow study, then we feed them. So 2 weeks without radiation and 6 weeks with previous radiation. And what was the other question?
No, I think that answers it. I had asked how often it was successful that your patients are able to.
Yeah, overall, I think about 90% of patients can eat without tube feeding.
Mm-hmm. So it sounds like overall you definitely favor the ALT flap, and I can understand why. Are there any patients that you see preoperatively that you're unable to perform an ALT flap on?
Yeah, if they have no legs.
Boom! Best part of the podcast.
I have a picture of a patient. he put both legs in ice up to the groin. And every time I show, that's the indication, a contraindication for ALT flap. But actually, there is a contraindication if you have a patient with obese legs that are really thick. Then you can't put that much tissue in the neck. Even we can thin the flap, but if it's really thick, you just can't thin it enough to especially make a tube. That's going to be very hard to do. So these patients will use a forearm flap that's a lot thinner.
Thank you so much. We heard this morning about some pretty innovative things you're doing for tracheal reconstruction involving some different prosthetic materials, and how there's not really anything ideal, but you've been very creative in some of the solutions you'd come up with. I'd love to have our listeners hear a little bit more about that.
Yeah, the tracheal reconstruction, to keep the lumen open, you need some rigid support material and then a thin skin flap for the lining. So our big problem is the supporting material. There's nothing commercially available you can just grab off the shelf. So initially we used the permanent material called a HemoShield elder graft, and that graft can integrate with tissue very well, but it's rather soft. So we have to put another graft there that's permanent, that's resorbable, but it's more rigid to reinforce the rigidity of the HemoShield elder graft. So that's how we started with. Then we also tried in animal studies with a Gore-Tex graft and some tissue engineered stuff, and we used a cross-linked collagen tissue engineered stuff. But once you cross-link, the origin becomes rigid, but it's it's like a piece of cardboard that never integrated with the tissue, so we really didn't use it. So still, now people are still working on tissue engineering for these like a porous like tracheal material, and or you can print a 3D trachea. But again, it's the material, not you can create something like look like a trachea. But if the material is not biocompatible with the tissue, then or not good for tissue integration, then it's not good for the reconstruction. And a lot of these patients, for our in our patient population, the cancer patients, they need radiation. So if your material doesn't incorporate with the tissue very well, and after radiation, it'll start to cause problems, infection, extrusion, and then ultimately failure. So that's area we still require a lot of work.
So today we had the chance to visit the anatomy lab with Dr. Yu and perform several different dissections. But one of the most interesting things we learned today was the ulnar artery perforator flap. So can you talk to us about the differences between the radial forearm flap and the use of the ulnar artery perforator flap? What do you like to use this flap for, and why do you think that this flap may be better suited for certain defects as opposed to the radial forearm flap?
Yeah, the radial forearm flap is a great flap. It's a hardy flap, kind of very hard to kill. Yeah, I always joke that you really have to be stupid to kill radial forearm.
Yeah,
Cut that out.
in your hands, maybe.
But it's a great flap. It has a very long, good track record. Everybody knows how to do it, and the donor site mobility is relatively small. But it still has a couple of things that we wish it could be better. For example, tendon exposure is common, and the skin graft to the area in the radial forearm area, it's very visible. Right? So these two things we can probably improve with the ulnar artery perforator flap, because when we design the ulnar artery perforator flap, the distal border of the flap is 5 centimeters above the wrist crease, so it's not as visible as the radial forearm donor side. In addition, there's virtually no tendon exposure in that area if you move 5 centimeters proximal from the wrist crease on the ulnar side, and it's also less hairy. So these are kind of the advantages of the ulnar artery perforator flap. Traditionally, I think the concern of harvesting the ulnar artery is the ulnar hand dominance, and that's kind of traditional teaching. But there are a lot of research going on, published in the last 10, 20 years, showing that that's probably not true. It's more like it's a equal dominance. There's actually no dominance. So if you cut one artery, the artery will just compensate to perfuse the hand. So based on these studies, we feel like it's pretty safe, and our experience also shows that prove that taking out the ulnar artery really does not cause any problem with the hand. So that's the so that's why we are using the ulnar artery more, just because of the advantages of less tendon exposure and more inconspicuous scar.
So along those lines, would you say you do not need to perform an Allen's test prior to performing this flap?
Yeah, I think that's also controversial, even in the hand surgery, especially some hand surgeons, where I train, it's a very hand surgery heavy, and these guys never believe the Allen's test. Mm-hmm. So I kind of learned that from my residency, and I did some Allen's tests in patients, and in a couple of patients, when we had a very positive Allen's test, the hand is white, and we prepared for a vein graft to the radial artery, and then once we harvest the flap, the hand is perfectly fine. So, but I think probably for the safe side, you can you can do Allen's test and prepare for vein graft just in case. But I think it's probably in reality you probably don't need it.
So during the dissection, you showed us exactly where these perforators from the ulnar artery would be found prior to actually visualizing them. So can you tell our listeners where we find the perforators?
Yeah, so these we kind of map the perforators in our flap dissections. So we then kind of average them and group them into like 3 groups: perforator A location, perforator B location, and perforator C location. And we realized that perforator A location is about 7 centimeters proximal to the pisiform, and perforator B is another 5 centimeters proximally in the arm, and the perforator C is another 5 centimeters more proximally in the arm. So based on these mapping, we can sort of predict where the perforators will be, so that'll guide you on how to locate these perforators.
So, among other things, I've deduced that Dr. Yu is good enough at what he does to work around patients that are fat and patients that are hairy. But on that note,
And fellows that are stupid.
no. We talked a little bit this morning at our resident breakfast about the role of vasopressors in flap surgery, and I know you had some interesting insights on that topic, and it has actually, I believe, come up on some of our previous exams as an in-service exam question. So I'd love to hear what you have to what you think about that.
Traditionally, people consider vasopressors contraindicated in free flap surgery, and of course the thinking is that the vasopressors cause vasospasm and cut off the circulation to the flap. But it's if you look at the experimental studies in the literature, it's always controversial. Some show matters, some show really doesn't matter, and there's really no good hard science. So at MD Anderson, we traditionally also don't use vasopressors in our practice, and we have kind of a common consensus with the anesthesiologists, and they should know that they don't use vasopressors in pre-flap cases. Then, and I was never a true believer of that, but. Because we do so many free flaps, and that's a tradition for so many decades, I didn't want to just say, okay, let's just change that. So when we had a very good kind of head neck anesthesiologist, I told him that maybe we should just treat these free flap cases like a normal cases. Don't worry about the vasopressor issue. And do whatever you need to do, and just don't tell me, so I don't have to worry about it. Then after 5-6 years, I said, so how are we doing? Maybe we should look at our results, see what happened with all these vasopressors. And so we started to review our cases. So we reviewed like 5,600 free flap cases at MD Anderson and looked at the vasopressor use intraoperatively. And to our big surprise, 2 surprises. Number one is 86% of the patient used the vasopressor in the operating room. So I gave a going round to anesthesiology. I said, you guys have been cheating us all along. You're not supposed to use it. And then the second big surprise is actually the use of vasopressors decreased the venous thrombosis, especially for breast reconstruction. So that's another big surprise. But actually, you think about it, makes sense. You raise the blood pressure, and probably constricts the vein. And so then we look at the pharmacology, and we talk about this with the anesthesiologist. They say that probably the vasopressor actually constricts the vein more than the artery, so that helps the venous return. So that's just one theory. It actually helps with the flap.
One of our microsurgeons will allow the use of vasopressors for most of the case, but when he's actually mobilizing the vessels, he prefers that they do not use vasopressors. So do you find that the timing is important, or at this point do you allow them to just proceed as they normally would?
Yeah, that's a great question. We actually thought about this. So we divided the vasopressor use into like 4 phases. The first phase is during anesthesia induction, and then the second phase is like from during the flap dissection, but before ischemia. Then this third phase is like 30 minutes before ischemia and 30 minutes after revascularization. Then the fourth phase is the rest of the surgery. So we look at the vessel pressure used during these 4 periods of time, and we actually also look at the vessel pressure used just before and after the revascularization, and we found no differences. So anytime during surgery you use vessel pressure, actually does not affect the flap survival. And of course, in the we call it first phase of P1, P1 to P4. So if you use a P1 during induction of the vessel, the average half-life for the vessel pressure is like 10-15 minutes. So by the time you do the flap, it's already gone from the system.
So Dr. Yu, you had a chance to show us some pretty unbelievable chimeric flap dissections earlier in our anatomy lab. Just wondering what your experience is with vein grafts, and do you use them? How often do you use them? And do they lead to higher rates of thrombosis and flap failure in your hands, in your opinion?
Yeah, in my hands, I don't use vein graft much. So if I know that I'm going to need a long pedicle, the recipient vessel is far away. So then when I design my flap, I design very carefully to create a very long pedicle so it can reach. So that way I can avoid a lot of vein grafts. So in my own experience, I haven't really reviewed it, whether vein graft increases the thrombosis rate. But my feeling is that if I plan well to use these vein grafts, it really should not affect the thrombosis rate. But I think one of my colleagues, he uses vein grafts a lot, and I think recently they published a paper about this, and actually vein grafts showed a higher thrombosis rate and failure rate. But I think that just reflects the really difficulty of reconstruction in these patients, not necessarily the vein graft itself.
Do you ever anticoagulate your patients after these big reconstructions?
For straightforward reconstruction without intraoperable events, I do not use any anticoagulation, just a routine DVT prophylaxis. Now, if the artery clots in the operating room, and most of these are because of the disease. You have disease, radiated artery, they just don't do well. Mm-hmm. And in that case, I give a low dose of heparin, like 400 or 500 units per hour IV drip for like 3 days. And in the operating room, I also give, before that, I give like 2,500 or 3,000 units of heparin IV bolus, then followed by 400 to 500 units per hour drip, just kind of take the edge off. I remember during one of the SR meetings, they invited a hematologist talk about the anticoagulation, and I still remember clearly she thinks that actually all your patients are probably at high risk because a lot of these are cancer patients, mm-hmm. and there's a long surgery. Mm-hmm. So these are, by definition, high-risk patients. So you should give a little bit of anticoagulation to take the edge off, but not necessarily fully heparinize them. So I think that the low dose of heparin probably in that situation may help.
So this probably doesn't happen too often in your experience, but if you are for some reason unable to perform a free flap for head and neck reconstruction, what are your local options? Yeah,
then kind of these salvage flaps, we have free flap failures due to infection, necrotizing fasciitis, or some other reason the patient really have no recipient vessels, if not previously radiation, surgery, neck dissection, or multiple free flaps in the past. And so in that situation, you are left with no options. Then I think the pectoralis major muscle flap with skin or without skin. You can skin graft on the muscle. Sometimes can be a compromised option. Or the latissimus dorsi flap. People usually don't think about bringing the latissimus dorsi flap all the way to the neck. And they, when I first used the latissimus dorsi flap, nobody believed me that it can reach the neck actually. And I took a lot of pictures, and actually one of the fellows, Alex Richards, he heard about I was going to do this flap. He came to the opera room just to see make sure that it reaches. So he took a bunch of pictures. Actually, we can pull the latissimus flap all the way to the TMJ.
Wow.
Yeah. So, but the key is you have to kind of create either divide the pec insertion in the humerus, or just create some shortcuts for the pedicle to go through.
Do you have to divide the clavicle to get it up that far?
No, not the clavicle.
You pass under?
Not above the clavicle.
Above,
yeah,
okay.
Above the clavicle, just on top of the clavicle. But I think what's limiting the arc of rotation is the pec major insertion. So if you divide this, then you have a lot of room.
Dr. Phillips, do you have anything you'd like to say or add?
I saw one last year
Oh.
with Dr. Yu, and this was a salvage. Everything was already used. I think they did at least 5 or 6 flaps that
Wow.
one would constantly just fail. Both pec flaps were already used, and
And the fibula.
yeah, I think he said we're going to do a latissimus. I think everybody said the same thing. We're not going to be able to get it all the way up there, and he did. So it can happen.
Yeah.
That was a very complicated case, but not something that's not routine at MD Anderson.
All right. Well, if it's not routine at MD Anderson, it's probably not routine anywhere. Well, thank you everyone so much for being here today. Much appreciated. I think our listeners will very much enjoy this episode. And until next time, thanks.
Yeah, thank you. I don't sing, but this karaoke is very popular in Asia, in China too. So I go to China, they always take me to a karaoke, and so when I have Chinese visitors here, I have a party, invite all the Chinese visitors home. So I thought I need to have a karaoke machine to entertain these visitors, and then the fellows, residents, and the PAs, they will enjoy it. And this is a good way to relax after double free flap case.
That's right. Which sounds like isn't that stressful for you anyway.